Okay, so welcome to everyone to yet another webinar hosted by the Center for Public Policy and Governance at FC College. Today's topic is the link between universal health coverage and the spread of COVID-19. Joining me today are two public health specialists. We have Dr. Samia Altaf, who is a physician and public health specialist. Her career has focused on the management and coordination of complex health delivery services for low-income populations. Dr. Altaf has also been on the faculty at Pakistan's Aga Khan University Medical College. She has served as a primary healthcare program officer for UNICEF and consulted for international aid agencies. She was the Wilson Chair's 2007-2008 Pakistan Scholar. She has also authored a book on Pakistan's health system titled So Much Aid, So Little Development, Stories from Pakistan. Our second speaker today is Ms. Maheen Dhanani. Maheen is a specialist in health services administration. She has a master's in health services administration from Florida International University. Maheen comes with a multifaceted experience of working in public health and health administration in both Pakistan and the USA, with various assignments in public health insurance, patient care coordination, family planning for developing countries, and fundraising for healthcare. So welcome to both our speakers. I just want to begin with a short introduction on the topic. Universal health coverage, as defined by the WHO, means all people and communities can use the promotive, preventive, curative, rehabilitative, and palliative health services they need of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial hardship. So the WHO defines three associated goals with respect to universal health coverage. First is that health services are provided in an equitable manner. Second, the quality of services should be so that they're helping users improve their health. And finally, health services should not put the user in financial difficulties. So in Pakistan, universal health coverage still remains elusive. We have abysmal public health spending, which is around less than 1% of our GDP, to be specific. Access to health as a basic right is still not promoted by subsequent political leaderships. Our experience with health-related MDGs was not up to the mark, and our experience with the SDGs also shows that there is little progress with health-related indicators. So I would like to begin with asking my speakers to talk a little bit about how we could have managed the spread of COVID-19 had we had better access to basic health services in Pakistan. And if Dr. Samia, you could please begin.
Thank you very much. And thank you very much for inviting me to speak about this issue. The first question we need to ask ourselves that what does universal health coverage mean in the context of Pakistani public? 80% of the people are completely outside of any system. They are left at the mercy of grandmothers or quacks or corner shops of doctors, people who call themselves doctors. And there is very little monitoring, and there is very little quality assurance. There is very little concern about what happens to them. So when we are, on the one hand, that's the situation. On the other hand, Pakistan is also paradoxically very peculiar in this sense that I have nowhere in the world found a health infrastructure that is spread out so deeply and so vastly into every region of the country. You have these districts which have district health centers and tehsil health facilities and VHUs and et cetera, et cetera. Of course, those are mostly on paper and non-functional, yet, there are those things on paper. So, when you look at these goals of universal health coverage in Pakistan, that it should be equitable, it should be good quality, and it should not be a financial burden on people, it just seems incongruous. It gives me, cognitive dissonance when I think of Pakistan. So that is something to think about. Before I leave this topic, I want us to think a little bit also about our spending on health or the health budget. You know, we talk about this, and we have spent almost the past almost 30, 40 years of my professional experience talking about it. But again, what do we mean when we say health budget? Because even for this year, meager enough as the health budget is, it has not been spent 100%. So what are we talking about again? You know, what does it mean? Suppose कल को आपको ज़्यादा पैसे मिल जाते हैं, आपके पास जो दुअन्नी है, आप वही तो खर्च कर नहीं सक रहे. You have not been able to spend the 10 pence that you have, and if you're asking for 20 pence, you know, what does that mean? So I will stop here and also just add as a discussion point later on that, you know, internationally many countries have been grappling with universal health coverage, and I spent many years working as medical director and director Department of Health for Washington D.C., where the U.S. government and the state governments have been trying very hard to provide universal health coverage. And I'm sure Maheen has a lot to say about that, you know, having the Florida experience. So let's just talk about this a little bit more, that what does it actually mean? So I'll stop here.
Okay, thank you. Maheen, do you want to jump in?
Yes, first of all, thanks, Saba, for having me on this platform. And Dr. Samia raised some great points here that I think not a lot of people are concerned with. So, I mean, that was really enlightening for me. And I think that when you talk about what we could have done if we had a greater access to basic health services, the first thing I kind of want to jump into is what exactly is access to basic health services when you talk about it. So when you define the effectiveness of a healthcare system, the three main things that I think that you should look towards is access, cost, and quality, which Dr. Samia also mentioned. So when you talk about access to healthcare, there are so many things in Pakistan that are posing as barriers for people that are burdening them. So we have political issues going on here, which are, I think, the most major concern for people. There is illiteracy, there's religious taboos, there's so much gender inequality going on here. There is unavailability of services, and there is a great hindrance for people in getting competent care. So when you talk about access to healthcare and how we could have had better strategies in tackling healthcare if we had better access, I think one of the greatest challenges that Pakistan faces, and I know Dr. Samia also mentioned this in one of her articles because I read it some time ago, is that we place a huge burden on tertiary facilities here in Pakistan. If we would have had policies in which we would have used the BHUs or the RHCs, and we would have involved more nursing facilities and LASWs in tackling healthcare, in which people would not have had to travel such far distances, in which they wouldn't have to come to cities and come to the big private hospitals, if we would have utilized the services that we do have, Pakistan does have it. So we would have used those smaller areas of our healthcare delivery system. I think that would have been great for Pakistan.
Very good points, yeah.
Yeah, so I completely agree with both of what you've said, and you're right. It's difficult to talk of universal health coverage when we're not looking at things like access, for instance, transportation for women, or decision-making abilities. So when we're looking at the challenges of universal health coverage, how would you summarize Pakistan's greatest challenges when it comes to universal health coverage?
Should I go ahead?
Yeah, sure.
You know, the challenges are basically very fundamental challenges, and I think that we need to recognize those, because without taking care of the basics, and without taking care of the foundational elements of this, we can try fixing things on the top, and those will peter out very quickly. For example, you know, the donors have been very good at providing short-term support to the government and given them ambulances or other transportation help. But those things only last as long as the donor funding lasts, and then it just dies out because there is no foundational or fundamental change that has brought about this access to services. And again, it just baffles. It is just, I find it very baffling that you don't really have to bring people into the hospitals and into the facilities. The facilities actually are laid out very close to people's homes. The BHUs and the RHCs are literally in the village, right close to people's homes. So to me, it seems that if the authorities are a little bit sensible, they would realize that it's a lot easier to take the services over there rather than transporting these sick and bleeding women and dying children and people with heart attack to bringing them this hospital and that hospital. So I think one of the challenges is this change of thinking, which is really, as you well know, a very, very big challenge and basically the fundamental challenge. And we need to just flip this thing around and look at it from the other side. But as you well know, Maheen also knows, and Saba, you also know, it is very difficult to convince the policy makers कि भाई आप जरा सा दूसरी चीज जो देखें. The other issue that you raised, Saba, and which is very important, that for women, making those decisions and having access to services is also something that is based very much on the status of women in the household. So again, if there's women like you and I don't have to worry about asking anybody's permission if we want to go see a doctor or whatever. So that tells you that if you are a woman of education and of a certain background, you can make decisions. So that also has a issue of access. So if we can't handle that and deal with that, I've had many discussions with my colleagues in the health department on this, and they always turn around. Now we are all old men and women, so a lot of these people don't even take this very seriously anymore. And they say, oh well, that is an internal family issue. We can't interfere with that internal family issue. I disagree with that. I feel that it's not an internal family issue. I think it's an issue of having the education and the ability and the understanding and the learning and the growth that societies go through. So,
yeah, I completely agree with Dr. Samia. Basic access to healthcare again is the biggest challenge for implementing UHC in Pakistan. And honestly, any change that we would bring to a public program, whether it is healthcare or anything, I think that itself has its own challenges. And just completely saying that we have to implement UHC in this amount of time is not possible because it's a huge change. And no system is strong enough to take that upon themselves so fast. I think that another great challenge here is the political rifts that we have, that not everyone is on the same page here. I think with COVID itself, we've seen that the federal and provincial government are not on the same page all the time. There's a lot of misinformation going on, a lot of disinformation, people not agreeing with each other, and the population doesn't know who to follow right now. So I think that is a huge challenge. Again, I think the budgets are today, and the percentage GDP will be recalculated. I hope is increased. WHO themselves say that the percentage GDP for healthcare should be at least 5%, whereas for the last couple of years we've been going up and down from 1.2 to 1.1 in that area. So I think that is a huge issue. As Dr. Samia said, that even for UHC, we do need money from somewhere. Now, the donors aren't giving it. Where do we get it from? So that is a huge issue. And I think one thing that many people don't touch upon is the technologies that we need, not so just for UHC, but generally for healthcare. I think we need to develop a unified health information system, have everyone's medical records on board. We don't have proper and enough data right now for which we can base all our research on. I think that is also important.
Thank you so much. I think I have a follow-up question. So essentially, I see it as a supply side issue, but also a demand side issue. So on the supply side, we've spoken about the low political priority given to universal health coverage, which is indicated from our health budget. It's indicated through our health policies. And on the demand side, we spoke about the link between illiteracy, between access and our ability to access quality health services. To what extent can we blame it on the demand side when we say there isn't enough political attention on healthcare spending? To what extent does the citizens demanding healthcare to be prioritized determine our access to universal health coverage?
Now, for this purpose, sorry, Dr. Samia, please.
No, go ahead. Go ahead. Go ahead, Maheen.
Oh, I just want to add a statement that for this purpose, the healthcare market is very different than the regular market, only because you never know when you might need healthcare. The average healthy person, anything can happen, and they don't know the next day they'll have to spend millions of rupees to get an operation or whatever. So I think that we should really focus on prevention as well as care. And as far as the political demand that you were talking about, of course, again, the whole GDP situation arises again. And I think that we should look more into that.
Maheen, you have hit upon actually the crucial point. You have hit upon a very crucial point that, healthcare market is turning into a consumer market, where in other consumer markets, the consumer knows what he or she wants. They want a pair of shoes, that is looks like this and, costs this and whatever. And if that product is more than what they can afford, they turn it down. But in healthcare consumer market, the consumer doesn't know what they want. They are given something that somebody else decides and they just have to pay for it. Exactly. The other thing is that, which is why that, 100 years ago or 50 years ago, or even in countries like United States and Western Europe now, this market is very, very rigidly regulated. So it is very rigidly regulated, certainly in United States, as you would know, Maheen, I'm talking, I know you know that already, very strictly regulated and very strictly monitored. Not only by the payers, which is, let's say, the government but also by civil society, by other monitoring groups. Precisely for this reason, which is not in Pakistan. Pakistan में डॉक्टर किसी बेचारे को कुछ भी कह दे तो वो कहेगा कि हाँ जी डॉक्टर ने ये कहा है. Even people who come from middle class families who are educated, they say this. They don't think they have the authority to turn around and ask the doctor questions. They say कि बस जी डॉक्टर ने ये कहा. Tisri is the third element that is, you see, prevalent, which has an impact on the demand side and the supply side, is this fatalistic attitude in our countries. I have people who come and tell me, we took this, and mostly women, poor women who die in childbirth and who die in abortion-related things that, yes, we took her to the hospital, yes, we went there, we did this, we did that, but in the end she died. So ji Allah ki marzi thi, maut likhi hui thi.
Yeah.
So there is this fatalistic attitude, which is just something which is so good for the doctors and the hospitals, that aakhir maut to kisi na kisi tarike se aani hai. There is a way one has to die, and once time comes, and then there is a bahana, there is an excuse, and all of that. So that is why I think, and the other thing is that in most societies, people who are vocal and who ask for change are people who have some understanding and some awareness and some education. And in Pakistan, those people have been completely co-opted by the system. When I say co-opted by the system, you find that most of these kids who have some education, even if not from outside and even if not from elite colleges, of course, most of the kids go to regular colleges. they have been co-opted by all the NGOs and the international NGOs, and the couple of corporate houses that are working in Pakistan in search of jobs, which are good jobs, because yes, their parents have paid money, and now they can't just waste their time advocating for free healthcare or whatever. So there is actually no effective demand for good healthcare services. Because you and I, when we need healthcare services, we get good healthcare services because we are able to pay out of pocket. We are well connected. We know where the private hospitals are, where the private doctors are. So we have what interest is it of ours, people like ours, to go out and say that this is not fair? Because if we go out and say that it's not fair, then we have to share our our advantage. We have to share our advantage. So, which is why I say that there is no effective demand for good healthcare services. आप ये देख लें तो I will, and I'm sure just as an example, when this current government came to power, in his maiden speech, the Prime Minister talked about infant mortality and child. He talked about child health and morbidity and mortality in children under 5, and he talked about maternal mortality. And he said these are problems that need to be fixed. And this was 2 years ago. So you can imagine that in these 2 years, not a single action has been undertaken by the government to fix these, or even to try to understand how to fix what the government did in the first year. खैर अब पिछले साल से तो everybody has been bent out of shape with this COVID thing. But even before that, what was the government? The government was opening hospitals, and they were doing this, that, and the other. So I personally think that, as Maheen said, that the maybe the stress needs to be on something else. We on the one hand, we really are very, very resource constrained. We don't have the resources. On the other hand, we have these multiple chronic, multi-layered problems, and we are trying to solve these without having any discussion, or without trying to make us ourselves understand what is the reason for these problems. We just assume that there should be more doctors, there should be more hospitals, there should be more medicine, and these things should be cheaper. Whereas what has happened is there are more doctors, there are more hospitals, there are more medicines, but all of these things are getting more and more expensive. And that has been happening over the past 20 years. So we should understand that clearly we should stop digging. If we are in this hole and we keep digging and putting in the same amount of resources and start chasing the same resources, then there is something wrong. So that is why I say that, you are right, Saba, that there is a supply side issue and demand side issues, but there is no thinking and no analysis that is being brought to the attempt at understanding these issues. I am very distressed actually, because now I've spent almost 40 years of my professional life in struggling with this, that we as physicians are very good at saying no, we will not be treating only the symptoms. We will find out exactly what's wrong with your liver. We will find out the pathology and treat that. But yet in the system, we are so reluctant to find out what's the underlying pathology. This increased morbidity and increased mortality is basically just a symptom. This is not the problem. This is how the symptoms manifest themselves. There is some underlying problem. So yeah, I would stop here.
Coming back to the topic of COVID-19, so some experts have been framing the pandemic as an opportunity for world leaders to renew the focus on public health. Robert Yates from Chatham House in the UK, I read an article by his recently, and he quoted Churchill when he said, quote, "Never let a good crisis go to waste," end quote. And Yates wrote in that article, quote, "If leaders take decisive action now, they may emerge from COVID-19 crisis as a national hero," end quote. So my question is, can the pandemic in Pakistan be seen as an opportunity to improve our public health systems? Because it is a window of opportunity, but that window of opportunity is closing fast. But to what extent do you think we can see this as a opportunity to reform our public health sector and, allow our leaders to become national heroes like Yeats puts it.
Yeah. Go ahead, Maheen.
So I think that as with COVID-19, I think along with UHC and everything, I think that a strong health system is what we had initially needed in order to tackle this crisis in critical times. A robust health delivery system is what is crucial in such times. Now, what UHC does do is that it provides a platform for health delivery for the whole population. There isn't It tackles the diversity. So, for example, I know many people who are unfortunate enough to have COVID-19, and they are seeking healthcare in the big private hospitals, and some people are paying as much as 100,000 to 150,000 rupees per day for their treatment. Now, what UHC would have done is it would have provided a basic platform for everyone, and there wouldn't have been any ups and downs in the system. Again, now there's not much we can do at this exact moment, but what we can do is we can take small steps towards UHC by implementing some of the factors that it has. So an effective administration for the hospital with proper governance is what I think what was required in this time.
Yeah, absolutely correct, Maheen. That there needs to be a certain baseline of service that should be available to everybody. And you are right, Sabah, that this is a tremendous God-given. I say this with a little bit of a trepidation opportunity, because a lot of people are suffering and a lot of people are dying. But even if things are so bad in the health sector in Pakistan, that even a little bit of change and a little bit of an improvement can have tremendous benefits down the line. For example, one example Maheen has given, which is that the hospitals needed to be brought up to speed and need to be administered in that sense. The other thing is that we've been talking ad nauseum, and we do that even now, about these hospitals being even now under COVID, these tertiary care hospitals and city hospitals being overcrowded. Yet even today, the district hospitals and tehsil hospitals are lying completely vacant. And of course, the 5% of the patients who are infected with COVID and who have comorbidities and are usually very sick are the ones who would need tertiary care and intensive care and would need ventilators and other sophisticated nursing care. But a lot of COVID patients will do very well with less technology dependent care, which can be provided with less skilled people. I met some people who came out of this quarantine center that was set up in Lahore, and their complaint was, these were young men who were quite healthy, and they were very angry, and they said, हमें तो जी कोई डॉक्टर ही देखने नहीं आया, और हमें तो कोई डॉक्टर ही देखने नहीं आया, हमें तो कोई डॉक्टर ही देखने नहीं आया. और डॉक्टरों को वो बातें बना. So I said to him that you are basically healthy. You didn't need a doctor to come and see. So these fellows turned around and they said, oh, really? We didn't know that. So who needed to come and see us? I said, well, if your relative had taken on the responsibility to check your temperature 3 times a day and to come and see you and take your blood pressure and stuff, or some lady health visitor or somebody like college students who can be trained कि temperature कैसे लेते हैं और दूसरा की, that was all you needed to see. Or in the worst case scenario, you yourself, you are a perfectly normal, intelligent looking young man, you could have been trained by us to take your own temperature and to jot down your own symptoms. So he said, my God, we didn't know that. So आप ये देखिए कि ये कितनी जबरदस्त एक protocol है, which can become part of your disease surveillance system forever going forward. Magar, where are the authorities? Where are the government people? Where are the technical experts? I am actually, although I've known Pakistan and countries like it for a long time, magar wo hota hai na, insaan ko kuch na kuch husn-e zan hota hai. One keeps thinking that these people will learn. I am completely appalled at the lack of competence and the lack of competencies that are brought to this crucial and horrible pandemic. But you need competencies that are of a wide range. You need all kinds of people, and you need all kinds of institutions to be standing together. For example, there is dearth of doctors. Of course, even under normal circumstances, without COVID, our doctors in hospitals and our doctors in health centers are, running only at 30 to 40% capacity. There are 50 to 60% of vacancies in all these facilities. Of course, that is under normal circumstances. Why wouldn't there be shortage of doctors under an epidemic? How do you fill that shortage? But there are many ways that you can fill that shortage. I'm sure Maheen has many examples, but I remember when I was working for DC General Hospital for DC government. We during just before the schools open, we need to bring all the children immunization up to date. So we have these programs, which we launch, and of course, to do these programs, we need doctors and we need nurses and we need paramedical staff and all. And we go to various universities, to Georgetown Medical College and to GW Medical College, and we say to them that we invite your final year medical students to come part of this. And the government passes legislation to say that you will be given 3 months off of your residency training. So there is an incentive for them to come and do this work over here under supervision. Ab agar aap ek senior doctor ko, you can give them 30 of these junior final year medical students, and they can do the work. But for that, you need legislation to be passed. For that, you need some regulation to be put in. For that, you need some discussion with their institutions to say these are the people, this is how they will be compensated. Koi wo nahi kar raha, kisi ko ye idea nahi aa raha. So it just tells me, it is appalling. There are 16,000 final year medical students in Pakistan. 16,000 people who are on the verge of passing their exam and getting to be doctors. They're all sitting at home. They're all sitting at home waiting for this pandemic to be over so that they can get back to the life of the doctoring that they have envisioned for themselves. मुझे तो जो भी मिलता है मैं उसको कहती हूँ, this is the life of doctoring that is in front of you, so it is better that you get involved. So you are absolutely right that this is a golden opportunity. This is किसी को भी अगर थोड़ी सी भी अकल है तो they should use this opportunity to say these are, and start with learning to deal with epidemics, because round the corner you are going to have the dengue epidemic, round the corner you are going to have the malaria epidemic, round the corner you are going to have diarrhea epidemic in children and pneumonia epidemics in children. तो इससे अच्छी क्या opportunity हो सकती है to learn to deal with epidemic? और आप medical students को, if you are a final year.
I remember when you came to speak at CPPG, you gave a very good example, and I agree with you. A lot of these efforts are budget neutral and requires tapping into existing resources that we have. I remember you spoke about the link between education and immunization when you said that parents weren't allowed to go back to work unless their kids were immunized, because their kids were not allowed in school. So if your kids are not allowed in school, you have to remain at home looking after your child. So there are a lot of co-current policies you can put in place which are budget neutral, which requires tapping into existing resources. So Maheen, do you want to add into that last sort of topic on what are some of the co-current policies we can be looking at?
I think Dr. Samia explained it pretty well, but I would just like to add that the government can start including requirements for example, for compulsory immunizations or for increasing the health education of the entire population. They can start adding health education in schools, which I think is so important for family planning, for maternal neonatal health, and for they can start adding programs like these to educate the people on what's correct and what is not. And I would also like to add on the epidemics that Dr. Samia talked about. I think that those are inevitable and a great action needs to be taken so that we can tackle this in the future. And I also want to add that the climate epidemic is also a great factor, and we cannot miss that. It is causing respiratory diseases. It is and will have a very bad future impact. And we need to improve our health delivery system so that we are capable of tackling those things that we cannot miss.
Yeah, thank you. So before we conclude, are there any concluding remarks you would both like to give on the immediate policy responses the government should be tackling in the near future?
Yes, I think that the government needs to put its house in order very quickly. I think that their lack of engagement and their lack of seriousness is just appalling. I mean, the indication is that the Punjab Chief Minister is in record saying that on January 3 we started thinking about what to do about COVID. The Prime Minister says in January 12 हम January से हम plan बना रहे हैं और सोच रहे हैं. The only plan that is out there to look at, the documentation, is a plan, National Action Plan for COVID response, government's response, is dated March 12. And it is not a plan at all. There is no strategy, there is nothing. You know, this piecemeal haphazard thing कि अब ये कर लो, अब उसको पकड़ लो, ये national जो disaster management agency है, you know, 1 month, 6 weeks or 8 weeks ago when it came aboard, they said, well, you know, everything, they will take care of everything and they are in charge of everything. This earlier this week, the Chief Justice called the NAMDA, the National Development Management Agency's chief, to ask him, and he said, we only have the responsibility to provide the equipment and the masks and the stuff that they need. So हमारा सिर्फ ये काम है, हम सिर्फ उन चीजों को procure करके इनको पहुंचा देते हैं. I mean, it is just amazing. Who is in charge? Who is looking forward? Who is looking at the data? Who is even talking about this? What kind of data do we need from Pakistan? I mean, we have no information. मुझे हर कोई आके कहते हैं ना जब that oh, you know, we have now 1,000 and some cases, so many cases diagnosed today, and I say, so what? They say, well, you are very callous and you are very this thing. But the point is, yes, you are telling me something. Then what is your point? What is the story that this number tells you? So many people have died in Punjab. And I say, so what? So what's the story that the number of these deaths are telling you? Are these deaths true COVID deaths? Are they because of COVID? Or are they in relation to other things with COVID? You know, in my own very back of the envelope calls that I make into the hospitals with kids that I know, you know, a lot of these people are dying because their management is very poor. No senior doctors are available. These people are not evaluated well, and there is nobody who can manage them, placing them on ventilators and taking them off of ventilators. Most of the people who get placed on ventilators die. And you know, these kids who are calling me from these Punjab hospitals, they say, madam, we feel that these people die because of the ventilators. These are ventilator deaths. Because nobody knows कि उनको कितनी tidal volume oxygen की जानी चाहिए, उनको किस तरह manage करना चाहिए. Ventilators are potentially very, very dangerous because of nosocomial infections. They give secondary infections to people. Who's watching out for that? So there is absolutely no monitoring of anything. Like Maheen said, that even the hospitals are not functioning appropriately, that who is responsible in the hospitals. There was, I read a couple of, I think last week's newspaper, that the woman who's in charge of the ICU in Lady Reading Hospital, who's I think an anesthesiologist or an infectious disease specialist, you know, she was going to quit. She's the only person over there in this large hospital who knows how to intubate patients who have to have a tube put into their windpipe so that they can be put onto the respirator. She's the only person who knows how to do that. So ये कहना कि हमारे respirators short हो गए, ventilators short हो गए, we need so many ventilators. For every ventilator, you need at least 7 staff persons to man that ventilator so that they are round the clock available, and you know, all of that. उसकी कोई बात ही नहीं करता. आ जाके जो everybody just says lockdown होना चाहिए कि नहीं होना चाहिए, as if lockdown is the silver bullet. that is the panacea for all of this. So I am very distressed. I am very, very distressed by this, that this is a completely unnecessary deaths. These are that are happening, or they are necessary deaths that are happening. I personally think that at the very least level, there should be an autopsy of the Taftan fiasco. देखिए ना, अगर आप गवर्नमेंट को रिस्पॉन्सिबल करना चाहते हैं कि भाई यू टेक अ डिसीजन, and if the outcome is not what it is supposed to be, you can't just shove it under the rug. I am a doctor, I give you a medicine, and if that medicine makes you bleed and it makes you break out into a hive, am I not duty bound and ethically bound to review this and say, why did this happen? I have to take responsibility for that. I am ethically bound to do it. Government ने जो ताफ्तान का वो बनाया था quarantine center, I personally think that that was the spark that allowed the disease to come into the country. Why are we not talking about it? I'm not saying that we need to blame anybody, but just to learn from that experience, कि किसकी responsibility थी, where did the ball drop, whether it was a financial issue, whether it was an administrative issue. I personally think that more than financial, it was an administrative issue, because very soon after that, you know, there was another camp which was set up in South Punjab, and I'm saying this only from reading the newspaper news. There was a camp set up in South Punjab, जिसमें problem हो गई थी. Some of the people got very sick, and the camp administrators asked the Nishtar hospital doctors to remove these patients and bring them to the hospital, and the Nishtar hospital doctors refused to do it. So the public started to blame them and saying कि ये कितने बुरे लोग हैं, कितने heartless, and they said no, they said no, we are not heartless. Under the regulations, because Nishtar hospital comes under tertiary care administration of the government of Punjab, and those camps come under primary and secondary, and Nishtar hospital comes under tertiary care. So they have different secretaries and different command centers and different authorities. We need to talk about that. Those people then left those camps and went off wherever they were going. Two people I know from those camps, जिन्होंने कहा कि जी हम तो तंग आ गए थे और हमने अपनी गाड़ियां बुलवाई और हमने कहा जहन्नम में जाएं ये लोग, हम तो घर जा रहे हैं. Wherever their homes were, they went homes, and of course they infected other people. There's no contact tracing, there's nothing. We need to talk about these things. We need to do a verbal autopsy of these programs. This was a quarantine camp that was set up in Taftan. This was a health intervention. This was a disease prevention intervention. We need to talk and what didn't work, so that next time when we need to do it, we should not make the same mistake. This South Punjab camp, which was an isolation camp, this was not quarantine, this was for isolation, because these were infected people. And of course, out of those infected people, some of them were going to become more sick. That is the nature of this disease, that some people will become more sick. Why is it that arrangements were not made that when people become more sick, there should be some arrangements to remove them from less sick people and to take care of these people appropriately? We should talk about that. So I think those things we should talk about.
Maheen?
I completely agree with Dr. Samia. I think she laid out all of the very important policy changes that should be made as soon as possible, especially when tackling this very, very dangerous pandemic that's going on. Again, I think 2 points that I think I would like to stress upon for immediate action. First one, for the general public, I think misinformation is creating a huge problem. They don't know where to go, they don't know what to do, they don't know who to follow or who to listen to. I think that the government should work together and try to unite and give the people a unified word and tell them exactly what it is. And the second thing, which Dr. Samia also mentioned again right now, was that the use of tertiary hospitals is being used more than it should be. There's overcrowding there, and we should utilize all the district health facilities and the smaller facilities in which people, like she said, how she met people who did not need a lot of attention from the doctors. We should have a place for those people who can go there and get the attention that they need.
But I'd like to thank both of you for attending our webinar today and having a very, very deep and fruitful discussion. I think the lessons to learn are for sure getting the information right. There are numerous budget-neutral policies the government should be looking to. It's not impossible. Other countries are showing how it can be done. It's just about tapping into the right resources and working towards, a goal that is achievable. We need to put our political decisions aside and work towards really people-centered, patient-centered public health care delivery. And it's not impossible. It can be done. So thank you so much. We really appreciate it. And I would just like to remind everyone watching that the CPPG webinar series are a new initiative by our center, and we'll be uploading more such videos related to public policy in Pakistan. So thank you once again.
Thank you very much,
Thank you,
Saba.
Saba.
And thank you. Very
Thank you,
nice
Dr.
meeting you.
Samia.
Thank you. Thank you. Bye-bye.